So our next speaker is Dr. Christian Schulz-Quach. Dr. Christian Schulz-Quach, him, is an associate professor of psychiatry at the Temerty Faculty of Medicine, University of Toronto, affiliated with the Wilson Center and the Institute of Health Policy, Management and Evaluation. He serves as program director of sexual and gender diversity in cancer care at Princess Margaret Cancer Center, University Health Network, and is the provincial quality lead for psychosocial oncology at Ontario Health. A psychiatrist and psychoanalyst, his work spans workplace violence prevention, psychosocial oncology, and existential psychodynamic approaches to serious illness and end-of-life care. He teaches and speaks internationally, trained as a palliative care educator through Harvard Medical School's program for palliative care education and practice, and is the recipient of the 2025 Capo Excellence in Education Award. He is also the creator, and this is really cool, he is also the creator of the documentary on queer aging and endings, which premiered at the BFI Flair LGBTQ+ and Film Festival in 2026. So the last time Christian spoke for us, he just grabbed everybody's heart. So I really want to welcome Christian back.
Thank you, everyone. This is my monitor over there? Okay, good. I'll work with it. Now, I've been sitting up there for a while, together with all of you. Is it a fair assessment that you're pretty full of information and emotions at this moment in time? I would invite you all to stay with me for another 18 minutes, and then you are free to go into a break. But before we do more input, I'd like to give you 2 minutes to turn to your neighbor, if you don't have one, turn around behind you, and just speak about what has grabbed you so far in the first 3 talks. 2 minutes, I'll get back to you. We live in a day and age of 30-second social media posts, and having to listen for 2.5 hours is a real task for many people these days. So my acknowledgements and disclosure are here on this slide. I don't have to say much more. I want to thank everyone here in the room, but specifically Teresa and Katie and also Samantha and her family for bringing the lived experience of what we're talking about today and meeting here together as advocates and as family members, as chosen family members, and of course those who are directly impacted by the lived experience. We already discussed, and I don't want to go into too much detail, that if diagnosed late, which unfortunately here in Canada is the norm, the survival rate, the 5-year survival rate is very, very low with this specific cancer. This is important because when we talk about cancer treatment and cancer care, we also talk about a holistic understanding of what the personhood needs. And the person is more than just the individual. The person is also defined by its social milieu that includes those who are important to us. Not just the immediate family members biologically, but also those who we would call our chosen family. Those who actually show up when we need them, those who are truly available when we send a text message or a call and reach out for help. Palliative care is a term that sometimes makes people uncomfortable, and that's okay. But I think it's important to contextualize it in a way that I will also show you here over the next slides by way of evidence, that it is more than just talking about endings. It's also a way of talking. I'm getting very echoey here. Okay. Fitting with the mortality topic. So, not end of life only, but whole of life. I think it is important to keep in mind that palliative care actually comes from coat, putting a coat or a sheath, a wrap of support around the whole person system. And the important piece is that we're not just doing it to be there at the end of life, but actually to improve life and extend life expectancy. We can show now through data that early integration of palliative care into treatment can actually prolong life. And that is not so counterintuitive for anyone who thinks about it from a social perspective. They will understand if someone feels well embedded, well supported, not alone, not anxious, and not depressed. They will make better choices, they will be more engaged in their care, and they will therefore also have a higher chance of survival. This is why the third point, concurrent and not consecutive, is important. We don't want to think about palliative care simply from the perspective of one thing has ended, now we're moving over to another, but rather as a concurrent parallel route of support while treatment is happening, active cancer treatment and symptom management. The person who has first shown to us that this is actually true, and the cancer research and academic world is well aware, is our colleague Tamil in Boston in the United States. In 2010, she did an amazing study, a randomized controlled trial, that simply showed that integrating palliative care early in lung cancer treatment actually prolonged the life of patients who received palliative care on top of standard care treatment, as opposed to those who received standard of care only. And it was a really significant increase of several months. This has now also been replicated in gastric cancer with 168 patients in the study I found to this topic. And again, it just goes back to the fact that someone who is getting good symptom management and has a higher quality of life can actively engage in treatment in a much more reasonable way and can also push through when there are difficult periods to go through. So let's go through the three pillars, body, mind, and table, that I want to discuss with you as we're heading closer to our break. So first of all, in stomach cancer, ESAS is a typical screening tool that we use to understand symptom burden more, and my speaker just before me spoke a lot about nausea, spoke a little bit about pain. I want to also mention fatigue is a significant issue in stomach cancer treatment. Patients being so fatigued that they feel they cannot really get out of bed, or they maybe cannot make it to yet the next appointment in the hospital. So cancer fatigue, and then also cancer treatment fatigue related to the impact of our treatment agents giving us higher fatigue and less mobility, can in itself lead to quality of life issues, including higher anxiety, lower mood. And this, as you can see, is a vicious cycle, because if you have low mood, if you have high anxiety, and you have fatigue, you will have less engagement with your treatment or ability to even engage, especially when you don't have a very close-knit social network. Sometimes pain in gastric cancer is underreported and a little bit considered as, well, you need to just deal with it. Well, if you have a little bit of stomach upset, even when you're not a cancer patient, you can all feel and experience how quickly it has an impact on your appetite, how quickly it has an impact on how you perceive the world. It can totally narrow your perception of the world. It can become very, very tiny and narrow, and you might not be able to actually interact with other people in a way that is conducive to your mental health and your quality of life. So really staying on top very early of pain management is a key component of palliative care symptom management. And it is also evidenced and very clear that if you treat pain too late, you have a much higher amount of medication you need to take to reduce your pain level again, to decondition your brain to fire alarm signals about something being wrong, as opposed to very early low-dose treatment, maybe even on a regular basis, to make sure that your pain doesn't reach crisis level. I will not talk extensively about nausea because most of you have more experience with it than myself, and it is also a bit triggering for those of you who have gone through it much. So I will skip this in further detail, but one of the most significant symptoms in gastric cancer, and what is important is we really need to understand where does the nausea come from, because there are very, very different types of nausea. They can come from motion, they can come from centralized direct brain activation. They can also stem from side effects from treatment. And it is very important to track down what is the most likely formulation and cause of nausea to then treat, because we have by now a significant amount of different treatment approaches for nausea available, but not all work in the same way. And so we need to really individually understand what we're trying to treat. I spoke about cancer-related fatigue. I just want to emphasize it again because it is a symptom that is often underreported and under-acknowledged, almost in the sense of, well, of course you're fatigued, you're going through a lot. That's not entirely correct. It's a symptom in itself, the number one symptom in cancer treatment, and when treated can actually really lead to significant improvement in behavioral activation, which in itself is a form of treating mood disorder. And so you see how everything interacts with each other, and where even as a psychiatrist, I'm very interested in the biological and the cancer-related body symptoms to understand how I understand the mood symptoms that are presenting to me. So let's switch over to that pillar two, to the mind. I would say it's not an overstatement, and by the way, the hidden pandemic statement does not stem from myself. It is used in the literature quite a lot, especially in gastric cancer patients, because we have a significant untreated, underreported, and underacknowledged amount of anxiety. Now, Samantha, when she talked about her story, mentioned anxiety, and I want to thank you so much for the way you shared. I found it extremely powerful and meaningful, reminding me of the importance of my work as well. But yes, there's also something we need to do about understanding that anxiety in itself cannot explain everything and should not be used as a moving someone to the mental health corner or mental health realm alone. I think that's why I tried in the slides before to show to you the relationship between body and mind symptoms. 30 to 50% of gastric cancer patients actually are dealing with anxiety. Is that understandable? Well, I think so. I think that anyone in a situational cancer treatment will have some level of anxiety. I think the important question that we need to ask is, how much is your anxiety impairing your ability to participate in life? So are you anxious because you can't participate in your life activities anymore? Or is your anxiety crippling your ability to engage in life? Two, by now, best researched evidence-based treatment options are BA, behavioral activation, and calm therapy. What is BA? Well, in the most simple sense, it's making you move, staying in motion, exercising. Exercising not by way of doing 200 push-ups every morning, but rather by way of actually staying in motion, walking around the block, getting out of bed in the morning. The important piece about behavioral activation is that behavioral activation and movement comes before mood improvement. So if you can find a way of getting into motion, into exercise, you will also see an improvement in mood. It will not be the other way around. Here you see again why social support, family, children, chosen family are important. Because it's not just a matter of the neocortex, it's not just a matter of people understanding that it's a good thing to move. It sometimes is a matter of getting a hand reaching out and saying, come on, I'll move with you, just a little bit. Calm therapy takes a different approach. Calm therapy is a palliative care intervention for advanced cancer stages in all sorts of cancers, but also in gastric cancer. And it is a meaning-focused existential intervention that provides an opportunity to discuss the individual question of what gives my life meaning. What provides me with the energy to get up the next day? All of us here in the room would probably agree that in, well, let's say 120 years, all of us will no longer be alive. That is not surprising. Everyone can cognitively agree and say, yes, that's rationally true. And yet, for most of us, the idea of endings and mortality is a bit upsetting. And it's particularly upsetting when you have a concrete timeline in front of you. And the question becomes, when you look at the timeline you have, no matter how concrete or relative it is, what do you see filling it with? What are the things that you actually feel strongly about needing to be filled within that gap? This is what calm therapy can do, and it is also a therapy, again talking about the social dimension, that actively includes family members and chosen family members in the treatment process, because it understands, and it was developed by colleagues of mine at the Princess Margaret Cancer Center, that lived experience of identity, that your identity as you're sitting there in your chairs is not just formed by your individual psyches. It is formed by who you go back home to, whether you like it or not, and those who are talking about you and reassuring you about your identity. So it is also a social construct. Sometimes medication can help, and sometimes it's the right choice. But medication is not typically a good choice for someone who cries. What I mean by this is we sometimes get referrals in psychosocial oncology. Can you please assess this patient? They are so sad they're crying. Well, I hope that I will cry when I get diagnosed, or if I get diagnosed with a cancer diagnosis, because that's a typical and normal grief reaction. If crying feels overwhelming to a point that I no longer understand why I'm crying, or even worse, if my crying withdraws and I go into a psychic retreat in where I do not have access to my emotions anymore, I feel flat, I feel blunted, I don't feel like I can express my emotions anymore. This is where, as a psychiatrist, I become much more worried. And this is a situation where it might be warranted to use medication. I want to just highlight one medication. The generic name is mirtazapine. It is a medication that has specific in cancer, gastric cancer use, a specific indication, because it is an antidepressant that has anxiolytic, so anti-anxiety properties. It has mood properties. It helps with sleep. It's a more sedating antidepressant. That's why we give it at night. It helps with appetite because it improves appetite, and this can be the primary indication for why it is prescribed in patients who lose too much weight too fast. It increases appetite, but it also has a formulation of the tablet that you can put underneath your tongue and it dissolves in your mouth. And therefore, for gastric cancer patients, it is particularly important to be aware of this medication. Now to the table, à la table. We have heard this before, but I want to go a little bit deeper about this. We sometimes have patients in the inpatient units in our hospitals that get visitors, chosen family members, direct family members from the core family, who sneak in food in situations where patients surprisingly don't like the hospital food, or where patients actually should not be eating food because they're shortly before an intervention or treatment or investigation, and yet the family brings in food. And sometimes I have colleagues who then say, how can they, how dare they don't understand. And then I often go back and say, well, have you thought about what love language this family speaks? And have you thought about what it can mean for a grandmother, a sister, a father, to come empty-handed to someone who seems like they need support? And so, especially when we're being culturally informed in a wonderful city like Toronto, where I'm very proud to be a citizen, when we think about the different ways cultures communicate love and care, we need to acknowledge that food is extremely personal, intimate, and makes you so vulnerable. And therefore, also the opposite is true. The lack of, the deprivation from food and from table scenarios goes way beyond nutrition. It is a direct and very, very crucial change in how you see yourself and your identity. The language of your care, the language of your love, will be altered fundamentally. And this is a very hard mental task to work through when living and surviving with gastric cancer. Maybe one more step. I have it down here. One important question that I sometimes ask is, what can you still eat with the people you love? Sometimes it's as little as air, but sometimes even just having an air meal together can be powerful for people who really want to nurture each other. We've talked about this multiple times. I have 5 minutes left. I'll bring it up once more. Those here in the room who are caregivers know this immediately and intuitively. Being caregivers is the most painful experience when you go through cancer care. How many caregivers feel, if only I could take it over, if only I could be the one who needs the treatment and not my loved one? How many caregivers, however, also feel that they have no right to say, today I'm just not feeling it, I can't do it, I need a break. And sometimes even maybe feel like I don't want to do this at all anymore. It is so important that we allow, just along the lines of a famous psychoanalyst, Winnicott, to be good enough caregivers. A good enough caregiver will occasionally fail and will always be imperfect, like we're all imperfect. What a caregiver should not feel the societal pressure for is to always be there 24/7 and to take on the burden of a very, very complex cancer treatment, such as in gastric cancer. So, we need to do much more than we do these days in healthcare for our caregivers. This is adult caregivers, this is also young caregivers, and this is also those who don't yet understand that they're part of the caregiving circle. It all has a deep impact for a very long time. Last input from my end, I spoke about it already. I think in Toronto, cultural humility is not just something to remind us of, it must be a given of our fabric of togetherness. When we walk through the streets of Toronto, we see so many wonderful cultural indicators. We see so many different food options, some of them remarkably delicious, some of them not so much, in my personal opinion. I'm a big fan of Markham, for that matter, but I will leave it at that. Everyone has their own preferences. Please keep all in mind, those who are professionals in the room, that cultural humility also means that we need to accept that Canada, and I thank my colleague who spoke before me in the beginning, is not doing a good job in understanding that other countries, like China, for example, like Japan, are doing a so much better job in addressing the needs of gastric cancer patients and their chosen families. On this note, some positive, uplifting news before we leave. The literature is becoming broader, it's becoming more voluminous, and it is also becoming more helpful. There are different phases that we've been going through in research, and at the moment, the recognition that quality of life is really significantly important for survivorship and also for acute treatment is coming to the forefront and is also increasingly a funding component of big research funding such as CIHR and other sources. So I think we're heading in the right direction. The integrated model that I'm providing here is one of thinking about body and mind as truly united. It is not just depression alone. Depression has an antecedent, and the other way around. If I am using the body, I will also get to a point of being able to modulate mood disorder. The mind we talked about already, and I spoke to some of the interventions available, including also psychotropics, but psychotropics alone will not solve what the mind tries to tell us. And then the table I spoke about as what is so important to understand about the social fabric that keeps us all together and provides our personhood that is more than our intrapsychic identity. Take home, refer early if you are a healthcare provider or someone who is supporting someone diagnosed with gastric cancer. Refer early or insist, advocate for being referred to palliative care, not because you're giving up, but because you actually want to extend life expectancy. Treat both together. We do have psychosocial oncology available in our major cancer centers, and Ontario Health is providing additional services for those areas where medical psychiatry and psychosocial oncology is not directly available in your hospitals. So you can reach out to Ontario Health for that matter. Ask about the table as a healthcare provider. Who typically sits around the table and what does sitting around the table mean? There are people who actually never sit down with their family members or their friends to have a shared meal. This end of the spectrum exists as well. The other end of the spectrum, however, is much more often frequent. Include the caregivers, I spoke about it, and then adapt, don't import. Don't tell other societies and cultures who have much more experience with gastric cancer what to do, but rather listen to what they are doing because we can learn from them. So thank you so much. It was wonderful talking to you. I have one request because I sat at the highest row over there. When you leave, could you all please be extra mindful about the very steep stairs and please take care of each other as we're leaving together. Thank you.
Thank you so much, Dr. Schulz-Quach. That is an excellent presentation. I think one of the biggest fears from patients, or one of the fears, is when you hear the word palliative or psychosocial care, because to a lot of patients that feels like giving up. And I really like the term that you used, whole of life rather than end of life. I think that really encompasses your talk, so thank you very much.